Now, the next area I want to go to is our evaluation and management. And I'm going to skip over the guidelines for evaluation and management. There were a lot of changes this year. I highly, highly recommend that you spend a significant amount of time reviewing your guidelines, especially for evaluation and management. Okay, when we get to the evaluation and management, a couple of things that I want to outline. Remember that you have a difference between your new and established patient for the office. So the first set of codes you come to here are for your office codes. And I want to make sure that I highlight what is the level of medical decision-making that is required. So straightforward or low. I also want to leave myself a little reminder that any prolonged services are going to be on page 27. Another thing I want to highlight here is my time. So remember that time, you can select your level of E&M either based on the level of medical decision-making or on time. So those two areas are very, very important. Same thing when we get to the next page, we want to make sure that we're looking at the level of service and the amount of time. The level of service and the amount of time. So same thing when we get to established patient. I'm going to skip over the 21. I have the 211. I have a little note I want to add there, but my straightforward and my time and my low and my time and my moderate and my time and finish out with high and my time here. I want to remind you that the 99211 can be performed by clinical staff because it has no presenting problem requirement, no time requirement, no medical decision-making requirement. Now, one of the other changes that happened in 2023 was the merge of our hospital inpatient and observation care services. What did not change is the observation status. So for those patients that are admitted or designated to an observation status in the hospital, remember that it doesn't necessarily have to be a place where they're located. It doesn't have to be a floor called observation. It's a status really that they are admitted to in the observation in the hospital. So we still want to make sure that we use the appropriate place of service. So I'm going to leave a note that says, check your place of service, right? You want to make sure that you're using that correct place of service there. The next set of codes that we're going to come to are those initial or observation hospital care codes. And just to annotate in the book here, what I think is important is that we remember that the new codes indicate that we're looking for medical decision-making or time. So again, I'm looking for my medical decision-making or time. So straightforward or low. I have my moderate levels, high level, and my time level. Now, all your evaluation and management codes still require a medically appropriate history and exam. I'm not highlighting that because I feel like at this point, we probably have heard that about 1 million times. So you know that it doesn't mean that there's no history and exam, because how did we get to that diagnosis? But it's a medically appropriate history exam. I'm really looking at my medical decision-making or time to select that level of code. Okay, the next section is a section that I feel kind of flip-flopped a little bit. So very much like they removed our observation codes and they're asking us to use the inpatient codes to report for patients, even if they're on an observation status. they actually added inpatient to those observations where the patient is admitted and discharged on the same day. Now, this is your CPT rule. CMS has a different rule. You're going to want to make sure you're checking CMS to see what those specific rules are for the admission and discharge on the same day. But one thing that's really important is that these codes for admission and discharge, they require 2 or more encounters on the same day. One of these is the initial admission and the other being the discharge encounter. And you're going to have those same requirements that you had for any discharge. And we'll talk about that in a second. That's also going to be required if we have a patient that is admitted and discharged on the same date of service there. So the level of service is straightforward or low, your total time, moderate, your total time, or high, and your total time there. Your discharge services from admission, inpatient, or observation, they have some requirements to them. The requirement is going to be, the code includes the final examination, the discussion of the hospital stay, the instructions for continuing care with the patient, preparation of the discharge records, any prescriptions and referral forms. So there you must be able to see that in that discharge there. Now, discharge, it has no medical decision making. So I'm going to write a note here, no MDM, only time is a variable. So when I get to my codes here, I'm going to notice that I have one for 30 minutes or less and more than 30 minutes on the same day as the encounter there. The next section we come to are consultations. And I think it's important to note that this is not covered by Medicare. It's actually not covered by many payers. I think last time I looked, there was only maybe 1 or 2 payers out there that actually acknowledged these consultation codes. But a couple of things to remember here is that a consultation is an evaluation and management that is at the request of another physician or qualified healthcare professional. So not a department, an actual provider, right? And we're using that to get a recommendation for a specific care or problem. The consultation also requires that the consultant's opinion and service they were ordered or performed might be communicated by a written report to the requesting physician or other qualified healthcare professional. So consultations require a request, a recommendation, and a report. So very important that we remember those key factors of the consultation. Now your consultations, again, medical decision-making or time, medical decision-making or time, medical decision-making or time, medical decision-making or time. Same thing with your inpatient observation codes, medical decision-making or time, medical decision-making or time, medical decision-making or time, and medical decision-making or time. Emergency department services. A couple of things here that I like to make note of. When we're talking about an emergency department, we're talking about those that are open 24/7. And I never thought that I had to explain this until I was working with a rural community hospital, and it was not a 24/7 emergency department. There are separate codes in the HCPT book for those types of facilities, not urgent care, but emergency department that's open less than 24 hours. So we are talking about emergency departments that are open 24 hours. And it even states that right here in the requirement. The facility must be available 24 hours a day. Now, there is no time for the emergency department. So no time, only medical decision making. Can you imagine a poor little emergency room doctor out there running from room to room, trying to track his time on what he looked at and who he looked at and what, like, that's probably not even remotely possible. So we're going to have our codes based solely on medical decision making. And the 99281 can be performed by clinical staff. I don't know how. Because we don't recognize incident 2 in a hospital setting. But that's the instructions that we have. It doesn't require a chief complaint, doesn't require medical decision-making, doesn't require any time. So we have our straightforward, our low-level medical decision-making, our moderate medical decision-making, and our high level of medical decision-making in the emergency department. Next, we're going to look at critical care. A lot of important things in critical care. First thing I like to recognize is a critical illness or injury acutely impairs one or more vital organs systems, such that there is a high probability of imminent or life-threatening deterioration in the patient's condition. So we've got a nice explanation of what critical care is. The other thing I want to point out here is critical care to infants, 29 days through 71 months of age. They have their own specific set of codes there to report those little bitty guys. And we also have our own set of codes to report for those neonates, right? So I always highlight those so it reminds me to go to the specific section there for those little bitty guys, right? It does give us an indication there that when a patient is not critically ill, but happens to be in a critical care unit, we can report those other E&M codes. So true story, a friend of mine's father was recently had a fall, and he was in intensive care or critical care. And then his status changed, but there were no beds available on the lesser care floor. So they just kept him in the critical care unit because there was nowhere else to place him. Now, if he's no longer meeting the definition of critical care, then we would report those specific E&M codes. All right. So very important to outline that information there. There's more information on our critical care services here, especially from a reporting perspective, because there are so many components that are included in critical care. So the interpretation of cardiac output measurements, chest x-rays, pulse oximetry, blood gases, the collection and interpretation of any other physiological data like an ECG, a blood pressure, hematological data, a gastric intubation, temporary transcutaneous pacing, ventilator management, vascular access procedures. Those are all going to be included in our critical care codes and not separately reported. So be very careful with that. We want to definitely make sure that we're not separately reporting anything additional to those critical care services there. And lastly, any critical care services less than 30 minutes in total duration, those are going to be reported with an E&M code there. And there's this really awesome table right here to help us in reporting our critical care and our additional time on critical care. So critical care is the first 30 to 74 minutes, and then each additional 30 minutes would be reported with that add-on code. Next, we're going to move into our nursing facilities, which our nursing facilities also are going to include those psychiatric residential treatment services. So I always make a little note here that it includes psychiatric residential treatment services. Now, a couple of other things. There was a specific problem complexity that was added specifically for nursing facilities. And let's remember that the type of care in the nursing facility or in a skilled nursing facility, they should be reported with those same codes. So whether it's long-term care or maybe a subacute unit or a rehab unit, we're going to use these same codes here. But they did add the problem complexity of multiple morbidities that require intensive management. So a set of conditions, syndromes, functional impairments that are likely to require frequent medication changes or treatment changes or reevaluation. The patient is at significant risk of worsening either behavioral or medical status and at risk of a readmission. So one thing that you're going to know about me is I always want to make sure that when it says significant, that we can support that this is a significant risk to that patient there. So just like our inpatient visits and our office visits, these codes are going to be based on the medical decision-making for the patient and time. The discharge services are based on time, not medical decision-making. So next to my nursing facility codes, I'm going to squeeze in here, no time, only MDM. 30 minutes or less and more than 30 minutes. Just remember there is requirements. So instructions are given for continuing care to all relevant caregivers and preparation of discharge records, prescriptions, referral forms. And the other thing that's really interesting is that it does not need to be performed on the date of the discharge. It can be, these services are face-to-face with the patient. They may be performed on a date prior to the date the patient leaves the facility. So very interesting. That's new instruction that we're receiving again in CPT. Now, it's important to know that the domiciliary or rest homes, we used to call them the assisted living codes, those codes have been deleted. And in their place, we're going to use home or residential service codes. Now, one thing that I want you to remember is these are not home care, not home health care, or not home care, however you want to designate it. This is not home health care. These are actual physician evaluation and management visits with the patient in their home. And there's no longer a requirement on CMS's part to have to indicate that the patient is homebound. That came out a few years ago. Maybe I think it was 2019. That might have been the year that they changed that requirement there. So we can use these home visits again for assisted living facilities, for domiciliary residential facilities. These are the codes that we're going to report. And again, these codes are going to be based on medical decision-making and total time. Here's your established. Same thing with your established medical decision-making or total time. The next area that we come to are the prolonged services. And this is one area that had a major overhaul again for 2023. So first thing is that if you'll notice here that they deleted the prolonged services with direct patient contact except within the hospital or other outpatient services. So those codes have been deleted. We're going to report those codes with 2 new codes that were added for 2023. Now, we always had codes for prolonged service on a date other than the face-to-face without direct patient contact there. So I want to make sure that you realize these are not new codes. These are previous codes. Now, some of the things that they remind us in this instruction here is that These need to be related to a previous face-to-face visit, right? So they are related, they are on a date other than the face-to-face visit, but they are related. And we should have some documentation that reminds us what are we doing. So prolonged services without direct patient contact may be reported when it occurs on a date other than the date of the evaluation and management service. So for example, extensive record review may relate to a previous evaluation and management service from an earlier date. However, it must relate to a service or patient in which a face-to-face patient care has occurred or will occur related to ongoing patient management. Very, very important to remember that there's some expectations there. This is reported by time, so the first hour, and we report each additional 30 minutes with the add-on code there. Now notice that there are a lot of codes that this should not be reported on the same day. They should not be reported on the same day. Now we have another set of codes. These are prolonged clinical staff services with physician or other qualified healthcare professionals. These codes are prolonged clinical staff services. So clinical staff services, this is a little confusing, so you really want to make sure you pay attention to the instructions that are given to us here. So these are to be used when an evaluation and management service is provided in the office outpatient setting, which involves prolonged clinical staff, face-to-face time with the patient, family, or caregiver, right? The physician is present to provide direct supervision. That's going to be required. And it's for a total duration of the face-to-face time with the family, the caregivers, by the clinical staff on a given date, providing prolonged service from an office visit, even if the time spent by the clinical staff on that date is non-continuous. So good information there. We're working on a time. These are timed codes that we're going to be working with. So the first code is for that first hour and the additional 30 minutes. Now, just remember that as we're looking at these codes, that we're remembering that this is what's relevant to the office visit. So we have to have a nice set of notes there to distinguish that information. And it also tells us that the starting point of the 99415 is 30 minutes beyond the typical clinical staff time for an ongoing assessment of each of the patient during that office visit. So what that means is that you don't need to exceed the total amount of time for the oldest or the greatest amount of timed code. If you look here, they give us a nice graph that tells us that this 99415 and 99416 can be used for any of those prolonged codes. The next set of codes are for those prolonged services with or without direct patient contact on the date of an evaluation and management. Now, these codes should only be used with the greatest amount of time codes. So that 99205, 99215, 99245, 99345, 99350, and a 99483. And it is used to report prolonged time by the physician or other healthcare professionals. So this is not the clinical staff time. We have a code for that clinical staff time. We also have a separate code for that inpatient service that exceeds the total time of those greatest timed codes: 99223, 99233, 99236, 99255, 99306, 99310. Those prolonged services. And the prolonged time are in 15-minute increments. Now, friends, I want you to remember that CMS has a very different interpretation of when time starts and for CMS than it does for CPT. So you're going to want to double check with CMS. You might even want to make a note here that says the time is different for CMS. I've actually had some students utilize this area to add those CMS codes and the CMS times for those codes. So each 15 minutes, and this is going to be in the outpatient department, the outpatient. And since it's a location, this is the first time I'm going to change my colors here, because this is for outpatient. This is for inpatient or observation. So just to make sure that that stands out to me, I'm using a different color there just to let myself know that the location is actually different for these codes.
Thanks for watching.